I'm Dr. Aaron Armstrong, an OBGYN. I work in Lakeside. Did this last year, glad to come back. So I kind of get a little background on you guys. Where are you in your training? What year? First year?
We started in January.
Starting in January? Okay, so almost
And we start rotation.
you set rotation now, things set up along those lines. How many are thinking about just family practice kind of area? General kind of thing? ER? Cool. Cool. Anybody think of women's health? That's kind of, you're going to do family practice, you'll do women's health. Definitely along that. If you're going to do ER, you'll probably do women's health as well too. So, like I said, I tell my patients, you know, the highway patrolmen are trained how to deliver a baby. They don't want to do that. So it's always good to know along those lines. But this is hopefully just a pretty laid back lecture, but I'll try to get as much information as we can for you along those lines. And please feel free to ask questions, any concerns, anything that pops up you want to ask about. Please don't worry about interrupting anything along those lines. So, like we're talking about today, normal labor and delivery, which I think it's always important to ask about why we study this subject, because why we want to know, because it's an unknown. I have a patient that comes into my office. She has a full-term baby. Will this kid fit or not? And in a safely time frame, and that's kind of the safety issue we have. So now, fortunately, fetal deaths are pretty rare, but 100, 200 years ago, that was quite a significant risk. It really was. And part of it is now kind of the science that we know about normal length and stuff. So we break it into three different stages. Like it says there, first stage is the onset of regular contractions to complete dilation. Second stage is complete dilation to delivery, and third stage is delivery of infant to delivery of the placenta. So the one that has the most variability, which one do you think will have the longest time, most variability? The first, yeah, exactly. It could be days, which is sad, especially the latent phase. And you tell a poor lady that you're not in active labor, I'm sorry you're uncomfortable, but you're not time for your epidural. It's just not one of those things. And that's not my happiest part of my job. But it is. So latent phase of labor, it says less than 4 centimeters of dilation, but what I'm really after is already having regular contractions and you're making cervical change. So that's the key thing. So it's not something that most of them can show up and say, hey, you're in active labor. It's something that they come to the hospital with regular contractions. We check their cervix and we check them again in an hour or so to see if they're making that change. Active labor is, once again, it's more along those lines of being that, making that cervical change over a consistent time. It talks there about primus and multips. When you are in active phase of labor, you are making about 1 centimeter per hour change in your dilation. With multips, you're about 1.5 centimeters. That's right. So they just progress a little bit. They have what's called the proven pelvis, is what I like to say. A lot along those lines. Of course, second stage is when you get to complete dilation to delivery. And we'll talk a little bit more about the time frames for those as well too. It can be as long as 3 to 4 hours for them pushing along the lines, which is hard for them to take and can lead to sometimes some exhaustion and stuff along those lines. But it is. I've woken several patients up to push because they're so exhausted they sleep in between the pushes. But that happens sometimes along those lines. That's the reality. Making progress, and we will. So when we talk about second stage of labor, let's go back to first stage. One more thing I want to talk about is trying to answer the question if the kid will fit or not. And so when we talk, the old term used to be arrest of dilation. Right? So we stopped dilating. We've gone from 1 to 4 to 5 to 6, and now they stayed at 6 and 6 and 6 and 6. Kind of the thing you have to think about now for considering a patient arrest of dilation or failure of the first stage is kind of the new term they might first use, is they have to be at least 6 centimeters. And we're expecting to be that for either 4 hours with contractions that we measure and actually know the strength and that they're adequate contractions, or 6 hours with the regular contractions that continue to stay there. So when I talk to patients, I say, if we come in recommending a C-section because I don't think this baby's going to fit, it's not just a split-second choice. There's time that's there. So it's something that kind of gives a heads up and give a realistic goal to along those lines. So that's it. So I like for my patients to get to at least 6 centimeters And if they don't make change within 4 to 6 hours, depending upon the contracture they have, then at that point I'm getting real concerned that this kid probably is going to fit through your pellets. And I feel confident at that point to make a recommendation for cesarean delivery. So second stage, back to second stage here. So failure of the second stage we would call arrest of descent, is the old term. The new term, once again, they're trying to say failure of the second stage. So once again, that descending, we are at complete dilation, and we'll talk a little bit more about station down the road, but now this kid has to keep coming down. He needs to continue to descend through the pelvis. There's different variables for that. We do break those moms into if they've had a baby or not had a baby. And we also break them into if they have regional anesthesia or not have an epidural. If you've had regional anesthesia, we give you an extra hour. You start out, if it's your first baby and you have no anesthesia, kind of the normal range is still 3 hours. If you get an epidural, we think 4 hours. This is documentation coming out from ACOG. So ACOG is the American Congress of Obstetricians and Gynecologists, which is kind of a big governing body for what I do. They presented lots of documents that I was presenting. One of them is they talk about how to prevent primary cesarean sections. So things you can look at that's reasonable to give these patients a chance to prevent a primary cesarean section. And that was one of the things where they continue to add the time frame. So if you give a lady who has never had a kid, and she has been pushing with an epidural now for 4 hours, right, because we added the 1 hour. And studies show, at that point, 3 out of 4 ladies that continue will not deliver vaginally. And so that's a point where you reason, well, hey, I don't think this kid's going to fit. And that's important. That's really important to determine this, because you don't want the kid to get stuck at any point. This is fine if the kid gets stuck here, but what we really don't, we don't want that kid to get stuck if the head's out and the shoulders get stuck. You guys talked about shoulder dystocia? You guys have? Okay, gone over that. It's okay. Release it for a second. And that's, I mean, that's one of the scariest things. Nope, you haven't? I see it through your life. No, maybe? No? Okay. Shoulder dystocia, and that's where, that's a sexual emergency. That's where the head has delivered, but the shoulder does get stuck on that pubic arch. So that's an emergency situation here. So I'd much rather a lady get stuck at the second stage delivery as opposed to dealing with the shoulder dystocia. Yes?
I think they briefly talked about it, Dr. Gibson did, when she was talking about large for gestational age.
Okay, yeah. So just a little touch at it and stuff like that.
She talked about them being little linebackers.
Yeah, no, exactly. They kind of plow through along those lines. We want it to kind of slide out. And there'll be a picture later on that kind of gives a demonstration of delivering that anterior shoulder, and that's where we get into problems with the shoulder dystocia. So we talked about 4 hours with an epidural for first-time mom. If going beyond that, 3 out of 4 women will not deliver vaginally. So with the multiple ladies already had a baby, it's 3 hours. So 3 hours with an epidural. 2 out of 3 ladies will not have a baby, will not deliver vaginally after that. It's kind of what that recommendation came from ACOG. So at that point, it's pretty reasonable. Hey, you've given him a good shot. I don't think this kid's going to fit. I think we need to proceed with the cesarean. And third stage of delivery is actually one of the most dangerous stages in the entire world because that's where you have the potential for the most blood loss. And that's where you deliver the placenta. So all those people working in the ER, family medicine, kind of thing, I'll throw it here. If you ever deliver a baby just all of a sudden emergently in the ER, and the baby's out crying, happy and healthy, take a breath, all right? Because this is actually where it gets the most dangerous for mom. Get that IV started. I beg you, get the IV started. Take the moment, don't rip that placenta out, get the IV started so you can have those medications that can help to stop her bleeding as quick as possible. So that's why worldwide, the #1 killer of moms is postpartum bleeding as far as pregnancy-related illness. In the United States, it's nowhere near the top of the chart because we have IVs and we have those kind of things and stuff going on. It's more related to cardiac malformations. Is what it's related to. Okay. Normal third stage is about 30 minutes. If you don't have the placenta out at that point, we start to get concerned about some kind of what we call accreta, where the placenta is attached more firmly to the uterus than it should be. It's going in. And that becomes, sometimes you have to do some kind of surgical procedure to remove that at that point. It may even sometimes be so significant where the mom has to have a hysterectomy at that point too, to stop her bleeding. Those are rare, but that's something you gotta keep an eye on. Most of the time, it's out in 5 minutes. It's going pretty quick. How long will your attending or the person overlooking you let you wait for the placenta to come out? 2 minutes. Okay, so it's gonna come out. They're not gonna wait for that very long. All right, so next phase, so the 3 Ps that we talk about here. So the components that kind of influence labor, the power, the passenger, and the pelvis. Those are the 3 things we'll see for success with having a vaginal delivery. First thing I kind of took a picture of is the female pelvis. Not all shaped the same, we all look different. Well, our bones and everything else looks different too on the inside. So there's 4 different kind of points, and most of us are not in one of those areas exactly. We're kind of a mix of all the above. Of those 4, which one do you think is the most likely to deliver a baby vaginally? You said D or B? I go with B, the gynecoid one. Hence the gyne side. So that's gynecoid. So the male side would be more the C, the anthropoid, more androgen type things. So we could see less. See how more shallow, or I guess, yeah, I'd say more shallow than the gynecoid pubic arches compared to the anthropoid there in C. D, you get more of kind of the platypoid. They're kind of more transverse. Is how those kids come across. We'll talk about that position as well too. So they can still definitely deliver. The one that has the hardest pelvis to deliver is C. Now, they used to a long time ago, they'll do x-rays of moms and try to do measurements and see if this kid can fit or whatnot, and we all found that that was just a waste of money and time. Pelvimetry is what they call that. So now it's just give them mom a chance. Just never kind of know what they're doing. So that's pelvis. Not much to that, but it's important kind of key point. Then we talk about contractions, so the power that's going to help deliver this mom. The number one question I always get is like, what do contractions feel like? And of course, from my personal experience, the way that most moms describe them are strong uterine cramps. That's what they are. Yeah, contractions don't last forever. They'll last for about a minute. It's one large muscle, so you can imagine like you can't hold your arms up forever. They're eventually going to fall down on their own, right? It's just muscle fatigue. Same thing with the uterus, it'll eventually wear out. So they last for about a minute, they gradually increase, get worse, and then decrease. Most effective contractions, they'll take your breath away. So it'll be hard to talk and walk through them. That's kind of what we talk about along those lines. And what's also too is the most effective contractions will actually start to be a little more coordinated. We see when moms start to transfer from that latent phase of labor to the active phase of labor, we actually see some cellular changes. We see some more communication between cells so that they can be more synchronized. It's kind of like, you have to imagine getting that last little bit of toothpaste out of the toothpaste tube, right? You start at the end, kind of work your way down. And that's how you get some more of effective contractions. So it talks here, rule of 5-1-1, which is kind of a term, instructions I give to my patients. So if you're having a contraction every 5 minutes, that'll last for about a minute for a good hour. That's frequent enough and consistent enough to thinking, hey, we're probably getting into active labor. And we need to see what's going on. So a contraction here or there, I'm not really that worried about it. I can tell my patients, I've never met a kid that snuck out. So I don't do worried about like if you wake up in the middle of the night and the kid's like, hey, feed me, come on, let's go. That doesn't happen. That doesn't happen. They'll let you know what's going on. So the second bulletin, so must be sufficiently strong and frequent enough, like we talked about there. And then talks about on that last bulletin, an external tachometer does not accurately measure the strength. We have to use the IUPC is what we have to, so intrauterine pressure catheter is what we actually have to see there. That moms want to see that, they can see it on the monitor, it goes up and down, this looks ginormous. With the external tachometer, you just tighten the belt and it makes it look worse. I mean, it's just a pressure gauge, is all it is. So it's actually the internal pressure catheter where we can actually measure stuff and put it on what we call Montevideo units, MVUs, because people in Montevideo is where they did the study. I think they're pretty tough ladies because so first we'll talk about on the left is that external monitor, the tachometer. One for heart rate, so just listen to the kid's heart rate, listen for that change there. And the one is the pressure one, the tachometer, looking for contractions. And then the one on the right, the internal monitor, actually they slide up inside. So one, the fetal heart rate will actually attach to the kid's scalp. Not always fun to tell mom, hey, I'm going to screw this little screw into your kid's scalp. That's not really cool, but It just becomes that important for us to monitor the heart rate, especially sometimes with moms that are obese and a little bit harder to monitor the heart rate. It gives us more accurate information. Then the IMPC just kind of slides right past the kid into the, around the kid. Water has to be broken in order to place these. You can't do it just under the membrane. It's just not as accurate. And plus you may cause an abruption, which is not cool. And so it actually fits in there, and at this point with that internal monitor, we actually measure those contractions, see how strong they are, in millimeters of mercury is what you're actually measuring. So Montevideo units is, they take the peak of the contraction minus the base, and they add all those up over about a 10-minute window, and we like for those to be at least 200. 200 to 300 every 10 minutes is considered an accurate, or a contraction pattern that's strong enough that we'd expect to have change. So when I went back and talked about that failure in the first stage of labor, and we talked about 4 hours of adequate contractions, that's what we're talking about. They have an IUPC, we can measure those Montevideo units, they're strong enough that they should be making change, as opposed to the 6 hours of unmeasured, just irregular, those that don't have the IUPCs with you. Any questions about that? So that was power, and that's what we're after. I mean, uterus is just one strong muscle, is what it's after. And so that's just the key thing. We've got to get a good contraction pattern. We've got to get them strong enough to think this kid's going to deliver. So the next thing is we're talking about the kid, right? The next P along those lines. Fetal line presentation. So that's something that's super important. Ideally, you should know the fetal line as soon as possible in this labor process. I have seen it, it's happened. Man, this lady's not making any progress. Why does she continue to be 1 centimeter, 1 centimeter, 1 centimeter? Oh, no, that's the kid's butt. Here we go. So you got to know which way they're lying, whether they're breached, they're cephalic, or going down. I did not do that, by the way. I would gladly throw them under the bus on that one. But so you got to know the lie, and it's following the spinal column, like it talks about there, to that of the mother. Vertex, breach, or transverse is kind of the one that you're after. And it's important to know what direction they are, which way they're looking, breach or transverse, especially transverse as well too. So we offer an attempt to vaginal delivery with patients that are vertex, meaning head down first. Breach or transverse, yeah, no, that's not coming out vaginally. Some kids, they did a lot of breach. There's a study that came out about 25 years ago that showed the significant complication risk associated with breach vaginal deliveries. And so at that point, it kind of became the standard to offer a primary cesarean section for any patient that continues to show breech presentation. Yes?
Do you know anything about hospitals that do today deliver breech? My friend,
Oh, yeah,
there's
no.
one like Kentucky or something.
Yeah, no, there's still some out there that'll give it a shot and try along those lines. But especially, once again, if it's first time mom, never had a kid, no. I mean, I'm not doing it. It's her 5th kid, and she's had 10-pound babies. Yeah, there's a chance you could potentially do it. You give a shot with someone who's had enough training, stuff like that. So it's not impossible. It's just, you gotta think about the circumstance. Because the worst case scenario is you get all the baby out except for the head. And then it gets started. You got cut, forceps, and hope you do it real quickly. So that's what you want to avoid. And you don't know that until the very end. Presentation. So presentation is that part determined by the fetal eye, right? If the breech, or the vertex, or the transverse. And it's a part of the body that's presenting into the pelvis. And that's key. And we'll talk more about here in a little bit too about which one we like, which one we prefer, and why we prefer that as well too. This is also something I will say with lie is something that can change quickly as well too. I won't throw anybody in the bus. I was involved in this. I didn't do the ultrasound, but I was involved in this. A lady presented for primary C-section for breech presentation. We confirmed with ultrasound right before surgery. She was still breech. Come back to the OR. She has her spinal. We're doing the surgery. Get all the way down to the uterus. And sure enough, the kid is head down. And she goes, you know what? When we were walking back here, this kid was really moving around the line. So most of the time, where they're going to lie there by 34, 35, 36 weeks. And that's the way they're going to lie. It's hardly you see a kid flip after And so I tell moms that come in and do an ultrasound and they're 30 weeks and the kid's breech, I don't care about that. That kid's probably gonna flip around, be fine there too. But once we get to 37 weeks, sometimes we'll offer what we call version. That's where we try to spin the kid as well too, try to put them head down. So it's something that can sometimes be something to change kind of quickly. I'll tell you the flip side of the story as well too on that. There was a case in another hospital where I was training, where mom was pushing, head was down, confirmed new head was down, 100% head was down. And then all of a sudden head wasn't there. And that fortunately triggered a lot of bells that, hey, this is not right. This should have been here, this should have been here. And that uterus had torn and had a uterine eruption. Uterine eruption. And so that kid was actually inside the abdomen at that point. And had to run and do an emergency C-section. So that's another key thing. That's why it's so important to try to identify what way the kid's lying as soon as possible. Okay, that's it. Next slide just kind of shows some pictures of different positions there. Face presentation there, so they're in a vertex line, but the face presentation on the left there. Brow, not quite as flexed as we hoped for. These are abnormal presentations, and then breech, and then of course shoulder. Those are all exposed. The breech, breech is not impossible. Shoulder's impossible to deliver that way. Brow's difficult. Face, it's difficult, but it's not impossible. And of course, breech is not impossible. Shoulder's impossible along those lines. So how do we monitor progress? And how do we know that mom's kind of following along? Of course, we talked about cervical dilation, cervical effacement, and fetal station. Now, it's all the answer, once again, can this kid fit? We're trying to follow this normal curve and to see if we can kind of get through this first and second stage of labor. And that's the next thing to talk about. This is kind of where we set our standard, right? So I think you'll find a lot of things in your practice of medicine that, not everybody follows the textbook. And so there's little variations off of the textbook. So you got to have some kind of goal you set by. And this is what we call kind of normal labor curve. Now you can see there on the bottom, hours in labor, to the left, cervical dilation, and kind of what we expect. This patient, so on the left, we see normal curve there. They had their latent phase early, so kind of for the first 8 hours. This poor lady was contracting but not really making that change. Then we start seeing that kind of aggressive change that we're seeing there in a more active phase of labor. It starts to peak up after that 7 to 8 hour time. We can complete delivery along those lines. So you can have different variations. So the poor ladies that labor latently for days and days and days, that prolonged latent phase there. B is kind of that prolonged active phase. It's just still kind of, she's going from like 4 to 4.5, 5 1/4, kind of just being annoying along those lines. And then C is kind of that arrested active phase. We're at that point, that's when I start getting really concerned. This kid's going to fit again. This is above 6 centimeters. We've made it to active phase of labor. This is above 6 centimeters, but you're just not making change. You start really kind of questioning, is this kid going to fit? So cervical dilation, it's different for each person. It's a skill to learn. It's a skill that takes practice. It's different. Most labor leaders will have these boards, like you see there in the bottom right corner, just to kind of help practice and to kind of get a feel for it. But it's something that takes, several checks to kind of figure out and get your feel. What they describe here as close 1, 2, 3, that's not for me, because my fingers are different, but for some of my colleagues, that's spot on. But, like for instance, for me, 2 centimeters, if I can fit one finger in with a little wiggle, I consider that 2 centimeters. So you just kind of have to get used to it, kind of know what's standard for you along those lines. Complete, and when we talk about 10 centimeters, you kind of lose it, but whereafter, when you feel, all you feel is head. You don't feel any cervix anywhere around the head at this point. That's where you feel complete along those lines. So then effacement. Effacement is the next part, and that's how thin the cervix gets. That's a challenge because it's termed in percentage. So who knows what 100% is, right? So unless you start out there, you don't know exactly, especially on a closed cervix. So 100% is a closed cervix, so I can't slip my finger in there, but I need to know how long it is. So that could be a little different for each, and that's when you see exams, that's when you see probably some of the most variation along those lines. So the average length of a cervix, anybody have any idea? The average length of a cervix? Any guesses? 4.5 centimeters. That's right. So if you can kind of base that upon your 100%, is where you think about that. But 4.5 centimeters. They are reported there as that kind of middle bulletin there, cervical exams as dilation, centimeters, effacement, and station. And as it shows there, shorthand, it's just a number dash, number dash. That's how we look. So we know that that's always standard. Dilation, effacement, and station. That's where you have it. So fetal station. So this is kind of a description of where the head lies in the pelvis, part of that descent issue, and it's based upon its relative location to the ischial spines. This takes practice as well too. You gotta kind of figure out how you can feel the ischial spine. So I encourage you, if you start, doing GYN exams, it's not just you're feeling for your cervix when you do that. I encourage you to start thinking about some of these landmarks and trying to identify those when you do those practices and you have those patients in the clinic and trying to identify where these are located. So ischial spines normally located about the 4 and 8 o'clock position. You do a cervical exam. Ladies laying on their back about the 4 and 8 o'clock position is where you would feel those. When the head is at the level of the ischial spine, that's what we consider a 0 station. Most patients at this point are complete. If you have someone that says, oh, she's 2 centimeters in 0 station, that's weird. That's not normal. You're like, really? I want to check that. Once we get to negatives are above the fetal, the ischial spines, and positives are below. So that's when they're starting to crown. They start a 3, 4, you can see head at the introitus. You can see that the labia is separated, and you can see head, see color. And so when you start kind of messing with their hair and making a new baby's hairdo and all that stuff. That's my other profession, baby hairdos. And so that can be a little subjective as well too, but it's not as much as effacement, because you can definitely feel the ischial spines. Everybody can feel that and kind of see where those are located. So most of the time as you progress, say if you're like closed, you're probably like a -2, -3. It's really high. You're like, is that the cervix or is that the tonsils? I don't know. Because it's just that high is where you normally see it along spines. But once you get to like 3, 4 plus, they should be more dilated and get close to complete, way beyond complete. Okay. So fetal position. This is significant for us to try, and this is actually one of the hardest things. I think we're still very challenged to try to determine what's presenting and how it's presenting in the pelvis, particularly with the vertex presentation. So we have head down first, right? What's key is we're trying to optimize our chances, right? We want the kid gets smallest diameter of their head to try to get through that pelvic ring, to kind of get out and get along the sides. The best position, we kind of like it talks about there, to try to find this, we have to follow the fontanelles and the sutures that we can feel. Fortunately, we have 3 bones in the back and 4 in the front, otherwise it'd be impossible. You just can't really determine which one's which. But so the first one we'll talk about, occipital interior. This is where the kid's looking down at the ground. So looking at the image there, that's the occipital bone that's anterior towards the top. Parietal bones on the left and right, frontal bones on the bottom there. Our landmark for vertex presentation is the occipital bone. Okay? That's just by standing elevation. So we're feeling for that lambdoid suture, so that little diamond shape is on the bottom there. The triangle kind of on the top is what you're feeling for. Kind of feel that position. This is one of the most optimal positions for delivering. And it's because what we're getting at this point is that the kid is able to tuck under that pubic bone and present the suboccipital bregmatic diaphragm. So that's the part where it's below the occipital bone here, coming up to the bregmatic point, and that has the smallest diameter for the head to try to fit through the pelvis. That's about 9.5 centimeters on average, is what it is. And that's where you have kids that have the most success on being able to deliver naturally. So, yeah, you can have a little variations. A lot of kids don't deliver just straight OA. Some will do what we call right occipital anterior, left occipital. So they're tilted a little bit, not completely. They're not completely transverse, and that's a different designation, but maybe 45 degrees one way or the other. The next it talks about is the occipital posterior. Once again, by convention, that occipital bone is on the posterior side. That's what we're looking at. Now this becomes one of the most difficult ways to do a vaginal in this vertex presentation because of the way that the head's angled down. Instead of being able to tuck under that pubic bone, now we have this extension that's going to happen in this neck as they hit their head on the pubic bone. Sometimes these poor kids come out and they're pretty bruised across the forehead because they've been just being pushed for hours and hours and hours against that pubic bone. This one is the occipital frontal diameter that we're after here. That's about 11.5 centimeters. 2 centimeters is a huge difference in trying to quickly be able to deliver and having a success. There's a lot of ladies in which we ended up with a primary C-section because the kid was occipital posterior and the head couldn't get past that pubic bone. So what you see there. Next, we'll talk about the occipital transverse position. Once again, you're just following that occipital bone, left and right. These kids normally need to rotate a little bit, and most of them they'll rotate on their own. They'll come around to that occipital anterior, or right away or left away as well too. Of course, this is just a diagram, kind of showing the different positions and talks about them. Once again, it all follows the occipital bone, and what you follow there through your guidance from posterior, anterior, right or left. There are, and so for breech, then the standard is the sacrum. That's what you have, sacrum anterior, sacrum posterior. For face presentation, it's the mentum, it's the jawbone. There, mentum anterior, mentum posterior. So, just an easy trick to know about that one. If a kid can talk about that, you know, some kids can deliver with a face presentation, but not all can. Because that's the other one that really kind of up in the air. Brow presentation still occipital, and they'll still be able to deliver for most of them. But the what we talked, the shortcut is with face presentation is mentum anterior. They may be able to deliver. Mentum posterior, you have to call the police, the MPs, because they're going to stop us. But just something, if you ever, a face delivery is, it's just weird. I mean, these poor kids, they come out, their face is all bruised, and you're checking them like, I don't want to poke their eye. It's just, it's kind of weird. Okay, so then we talk about movements of labor. As they kind of come down through the pelvis, these are kind of the cardinal movements that we talked about. The engagement, the flexion that has to happen. Talk about internal rotation, extension, external rotation, and expulsion. I think this picture, the next picture kind of gives a little bit, and that's a little bit hard to see, but. So the first picture there, so we're talking about right before engagement, and the second one is it's coming into engagement, and it's doing this flexion, right? So it's tucking its nose down, so it's happening. It's trying to get to that suboccipital brachiotic membrane into the pelvic, into that entrance, because that's the smallest diameter. Then number 3 there, so you get full descent, and we have this internal rotation. So look, and you can see that the kid in picture 2 is kind of looking to the side, but now in picture 3, it's looking more down towards the ground. We're getting to that occipital anterior position, so that's that internal rotation. We begin now some extension. You'll see when kids deliver, their head kind of comes out of the vagina and then extends up along that. That's just the natural course. We'll talk about forceps and vacuums, and the natural course that you do is you kind of a J shape because you're coming that extension that you're trying to accommodate well through. So you kind of come out and up. This is what happens there. 5, so complete extension. You see there. 6, this is where it turns back, right? So we've gone from looking OA to now we're looking left or right, depending on where our body's positioned and so on and so forth. 7's that we're getting that anterior shoulder out, right? So avoiding that dystocia. And then that's the 7 and 8 are essentially expulsion along those ones. Once you get that, normally get the shoulders out, the kid just slides right out after or jumps out sometimes along those lines. Oh, so these pictures, fair warning. This is crown. So this is a good, 4+ station. She's making good effort. And they can really kind of get along those lines. We don't want to go real fast, we don't go real slow. And that's normally when I'm doing my hairdo, right there. See how they're kind of guiding the head out? So that left hand there is up on top of the head. It almost kind of controls. You don't want to go too fast. You don't go too slow. So sometimes I'm actually pushing against the kid to control it. Just for it to have a smooth motion. That bottom hand there, at that point, they're supporting that perineum. They're trying to keep it from tearing along the side. So it's almost like you're kind of, once again, you feel like you're fighting the kid a little bit. You're kind of holding that perineum together to help support that so they have good control along the lines. So this is in the face. So here, looks like a great picture there. We've seen this is that, once again, that rotation that's coming back there, that restitution that we talk about. And we're looking back the way that we should be. So this kid was facing down, but now we know that this kid has always been body, we know is turning to the mom's left side. And that's the position where they are at this point. Supporting the head, so as you can see there, the fingers and thumbs are towards the patient's, towards the infant's face. So you're kind of pointing away with the head, because that's how you want to support. You don't want to go the other way. It's just not as accurate for your next movements that you can do. Okay, so here we've got that anterior shoulder. So this is where we're actually, mom's legs are back in what we call the McRoberts position. And we're kind of guiding that head towards the floor, because we want to get that anterior shoulder out from under that pubic bone. This is the shoulder dystocia. So this is where we get it. Scariest thing that I do is have one of these, honestly. Take them all, I can do a C-section, I can do a hysterectomy, and whatever. The scariest thing any of us do is when you get a kid like this and they're stuck. And so that's where you have that gentle guidance and you're trying to get that shoulder to come up under and to get free of that pubic arch there. So there's different maneuvers we go through to help release that. Sometimes it's just a matter of kind of getting the mom's legs further back, as far back as they'll go. Suprapubic pressure, not fundal pressure. We're not going up to the top of the kid and pushing. We're going just above that pubic bone, and we're trying to help, once again, kind of push that shoulder up under. That's another maneuver that you can do to help to release there. Then you start getting about, if those don't release, then sometimes you can just spin the kid, try to reduce that down. Sometimes then we have to reduce down to push the shoulder. Sometimes we'll have to do a episiotomy, actually make a cut on the mouth to try to make room for along those lines. And unfortunately, sometimes too, I mean, not uncommon. It happens more frequently than we know, but clavicle bones will get broken on these kids. So, and that's nothing that we like to do, but you know, if this kid stays there for 5 minutes, this kid's not breathing. There's no oxygen getting to this kid right now. So we can't breathe for 5 minutes. I'd much rather have my clavicle broken than stop breathing for 5 minutes. And that is just kind of the tough situation I have to do sometimes. Sometimes too, when you reduce that arm, sometimes the humerus will be broken as well too. So, I mean, it's not ideal, not what we hope to do, but it's just what happens sometimes. It's like a kid. But once it was reduced, and 99% of the time it doesn't happen, but when it's there, it's quick and emergency. This is why I'm not a huge fan of first-time moms delivering at home, you know, because if you need me pretty quickly. So now we're delivering that posterior shoulder. So anterior shoulder down. Once again, we're kind of, this is the expulsion portion, kind of the end. We're delivering that posterior shoulder, kind of coming through that perineum. You can see in that back hand there, they're supporting that perineum. They're not allowing it just to kind of, you know, tear if it's going to tear. They're just giving it some support, because we don't want it to tear any more than it may have to. Okay. Any questions about it? Normally happens pretty fast. Normally it's pretty quick and happy and painless, or not painless. It goes well, and you got a nice, happy, crying kid, and that's what you're after along those lines. But every once in a while, those are the things you got to be prepared for. And that's why it's so important to kind of know that position, know that lie, know where they are from the get-go. So you got to be prepared for those things, and kind of fight them off as best you can. So we're not barbarians. We do kind of help with pain. Some moms choose not to have anything, and they'll have help. Some moms do a fantastic job, and they just do great with it. And they could do it 5 or 6 times, and that's just it. Some moms, and you'll find this too, not only just in obstetrics, I think you'll find this just evident in most people. People just tolerate pain differently. That's just the truth. That's just the fact. And so some moms are better to do it, and some are not. But we do have options. So IV medications, like Stadol is one of those that we can help out with. It's what I tell moms, I don't mean to be mean, but I can't give you IV medications beyond a certain point. I mean, normally 6 or 7 centimeters. It's mainly because whatever I put in your IV is going to go to the kid too. And of course, one of the number one side effects of any narcotic or anything like that is just, being sleepy. And I don't want a sleepy kid born. I want a good, happy, crying kid that's awake and alive. And so I do tell moms, there's a certain point where I can't give you anything. It's not because I'm cruel, but it's just because I know your pain will be over, but I want to make sure this kid's wanting to wake up and be breathing and doing all those things it needs to do immediately after being born. So the Stanel's one. Sometimes we give morphine. Nubane's another medication sometimes we can utilize. Agonist, antagonist kind of effect to it sometimes. Local, so there's people used to do back in the day do pudendal blocks. Fortunately now most facilities have CRNAs or anesthesiologists can help and do epidurals and things along those lines. So this pudendal block is not going to help out with the early part of labor. It's mainly you're just going to, once again, the pudendal nerve, and so it'll help out with the mainly with the second stage of labor there. When you get complete pushing, those kind of things, because it'll help to numb the ball barrier. But you have to do it like when they're around complete, so you can kind of still have access to the ischial spines to be able to do it. Of course, epidural. I tell my patients, you can have an epidural up until we hear the baby cry. Then that's probably too late. We prefer to do epidural versus a spinal because it's just location. And we can have a continuous drip with that, keep the time. Spinal actually utilized for most of our C-sections because you have to get a better anesthetic with that. They're more numb, they don't hurt as much. And Augie says there's a complication, maternal hypotension. So if any lady ever asks for time for my epidural, any good nurse, the first thing they start doing is give them an IV bolus. Because they do. They get a little bit of hypotension in their gums. And that is related to sympathetic, parasympathetic. When we do our anesthesia, then of course we're blocking that sympathetic feed. And then the parasympathetic will take over and cause hypotension, decreasing pulse, and all the other things that the parasympathetic vagal nerve will do at that point. That's why, for instance, moms that are paralyzed, they'll come in, their blood pressure's high, they're having all these sympathetic responses, and they don't feel a thing. They're not hurting, but they're having all these sympathetic responses, and so then they'll give them an epidural, even though they're paralyzed, can't feel it. But that'll help control their blood pressure. Control that, kind of get that a little bit more control. Okay. I'm sorry, one thing I wanted to say on my notes, when we come back to position-wise, too, I forgot to mention, so we're talking about occiput anterior, occiput posterior, and occiput transverse, and those kind of things. The other thing that can sometimes be a complication is what we call asynclitism. And that's where the head is, instead of straight on, it's tilted one way or the other. And that can be direct. Once again, it's all coming back to how can we get as close to that suboccipital pragmatic diaphragm there to get that smallest diameter. And if the kid, instead of coming out this way, is coming out this way, you're just going to increase that diameter.
Could you repeat that word again? What was it called?
Asynclitism. So it's A-S-Y-N-C. L-I-T-I-C. Yeah, A-S-Y-N-C-L-I-T-I-C. Okay. So this is a pudendal block. Once again, so this helps with pudendal nerve, it's rheumatoid variant. It's not going to help with early stages of labor. But this is something that was utilized before. We had a lot of in-house anesthesia. So you don't see it very much now. More third world kind of country kind of thing. That's what you see. So episiotomy, yeah, the first bullet, they just don't recommend doing it. But there's a scenario, so it's not a routine thing. So it used to be that, oh, she's going to tear, we'll just cut, and it'll be a better tear, it'll be more, smooth edges and come together more nicely, less pain, less repair. So, and that's not what they found. They actually found that if you did an episiotomy, you're more likely to have a 3rd or 4th degree laceration, which means we're gonna start tearing into the anal sphincter and into the rectum as well too, which leads to fecal incontinence and pain and problems down the road. So, the recommendation now is just to kind of let moms tear on their own. If they tear on their own, they're less likely to have that 3rd and 4th degree laceration. Yeah, there is a place and time for it. I tell moms, I don't do it unless I think it's absolutely necessary. Let's say a mom's pushing, she's pushing well, the kid is maybe 3 or 4 pushes away from delivering. But I don't feel confident about the heart rate that that kid's going to last and do that well at all. So I'll go ahead and make the episiotomy at that point and help to deliver, ideally with the next push. So that's the place for it. That's the position for it. Only if there's really kind of a fetal indication for it. Once again, that shoulder dystocia, we talked about that. Sometimes you make that episiotomy just to kind of open up for size-wise. Fetal macrosomia, once again, those large kids. But most of the time, if they're going to deliver, they're going to deliver on their own. So it does increase your risk for bleeding, does increase your risk for hematoma, and like we talked about too, that 3rd and 4th degree laceration as well too. Increase in swelling, infection, fecal incontinence, like we talked about, and pain during intercourse, something very, very common. So one of the indications too, if you're going to do an episiotomy, they do talk about encourage you to do a medial lateral, that picture on the right there, as opposed to midline. So instead of going straight down, you go off to the side. We do see some decrease in 3rd and 4th degree laceration, being decrease in sphincter tears and decrease in rectal mucosa tears as well too. So they do recommend doing that if you have to do an episiotomy. I will say this, the key thing too, if you ever have questions or concern, like, is this a 3rd or 4th degree laceration, you can get some help to identify that. The best time to repair those and the best chance for that woman to have the less complications with that is at that time right then and there, when you repair it right after delivery. So it's best to have those properly identified and repaired as they should. Otherwise, it could be a kind of a long-term healing process for you. And of course that, if you ever have any questions about that, then you just perform a rectal exam at that point. And you could best identify if you've got any mucosa or sphincter responses. So, the whole process of this, right, this normal labor process, we're asking the question, well, can they fit? Is this, will they make it? Well, sometimes it doesn't. And so then, of course, we end up with a C-section, which, like I say, 100 years ago was really kind of last-ditch effort. I mean, these moms they're dying, is what it was. There's a chance to kind of save the kid, because there's not a great chance that mom's going to do it. But fortunately now we have a better understanding of it, and it's still considered major surgery, but much less risk, and it's appropriate. It's very appropriate at different times. So indications, so a previous C-section, now you can still offer a lot of ladies who have success. If you had a breech delivery and they ended up doing a primary C-section for breech, there's still about a 60 to 70% chance that lady can have a vaginal delivery with subsequent pregnancies. So it's not impossible, but it's something that in the right situation, the right time, right counseling is a possibility that could be done. Fetal distress is one thing I always tell my patients. Sometimes the baby determines that we need to have a C-section. And then there's a lot of things that could do that. But we're monitoring the heart rate. The heart rate goes down significantly for a prolonged time, and we can't perform interventions and it's not resolving, then it's time for the baby to be delivered. Malpresentation, once again, that shoulder presentation is not going to deliver. It's not going to do that. Transverse is not going to deliver eventually. Active maternal HSV, such a high risk to the kid that if the mom either has an active vaginal lesion or she has symptoms that she's getting the lesion, that she's actually shedding that virus, it's recommended for a primary cesarean delivery. Hopefully we'll try to catch these. If they have a history, we'll put them on prophylaxis around 35, 36 weeks to try to prevent that. But it's a significant thing. If you ever seen a kid with herpetic infection early on, it's sad. I mean, it's long-term complications. I don't bat a heartbeat at offering a lady C-section for that, because it's just there. Severe maternal condylomas. Some genital warts. Genital warts are going to tear significant ones, and they're not going to come together easily, and you're going to have some significant bleeding to manage. This is sometimes for significant maternal condylomas. And there is some concern about maybe risk to exposure to the kid as well, too. Some of these kids develop like throat cancers and stuff like that. kind of weird to see. But ideally, you treat that, and you can treat condylomas in pregnancy as well too, so hopefully you try to reduce that risk. But that's always a risk there. Fetal congenital anomalies. Yeah, they're just sad stories. There's some kids that just don't form the way they're supposed to form, and they're never going to deliver naturally. So, hydrocephalus, I had a lady that was had a hydrocephalus kid. Well, she never really followed up. She didn't do what she was supposed to do a long time. And she came into labor on her own. Well, this kid, head diameter was almost 16 centimeters. That kid was never going to be born vaginally. Never along those lines. So they had to perform a C-section. But there were some sad things like that that just happened. Those kids would just never be born vaginally. Placenta previa abruption. You know, so placenta previa, does anybody know what's a placenta previa? Anybody have any idea?
Where it covers the.
Right, it's covering the cervical, it's covering the cervical opening, it's presenting, yeah, we can't let that cervix dilate, because if you dilate, then that starts tearing, and that starts causing an abruption essentially, and that's mom bleeding, but that's also baby bleeding. And so those ladies unfortunately get a C-section recommendation for that. Failure to progress, once again, that's that whole question. Is kid going to fit? So failure of the first stage, failure of the second stage, and then we make that recommendation. HIV is another one. They have pretty active HIV, and their viral loads are pretty high, and then they'll recommend a cesarean delivery versus, yes?
Is it true that if you have a C-section, your next child will always have to be a C-section?
No, that's not true. So when we talked about previous C-sections before, you can attempt a vaginal delivery afterwards. So, like for instance, especially for like indications like a breech presentation, I mean, that lady had no chance, we didn't give her a chance to try, that she can deliver any kid vaginally. She has about a 60 to 70% chance of having a vaginal delivery with her next kid. And so she can have that opportunity. You gotta have the right facility, the right physician, the right team available, because the risk with attempting a vaginal delivery after a C-section or a total lack of trial of labor after cesarean, the scariest thing is what we call uterine rupture. And that's about a 1 to 2% chance. So it's low, but it's a surgical emergency. Once again, that's that kid that head was down, then head was not down. Where'd he go? Yeah, if that kid's not out in 5 minutes, then the kid's probably not going to make it. Kind of thing. So you got to have the team right. You got to have anesthesia available 24 hours a day. You got to have the surgeon in house and available to deliver. So it's not impossible, but definitely something you talk to the patients about. And a lot of moms, some are interested in, some are not. Some are like, well, I just like the schedule. I know the date. So we talk to all the patients about that. It's a big thing. It's on another list on the forceps and vacuum, but I'd also put it up on this one. But maternal cardiac or pulmonary complications is another reason for cesarean section. If they can't really, if they can't really put that pressure to push, such as like patients with pulmonary hypertension or Marfan syndrome that have significant dilated aortic roots or something like that, then it's probably recommended for a cesarean delivery at that point, because we can control their pressure a little bit better with that, as opposed to that real strong Valsalva maneuver they're going to make as they're pushing. Okay, so complications to baby. So while baby's inside, right, baby's swimming around in all that water. It's really cool, but it really breaks mom's heart when they realize it's actually the baby's urine that they're swimming around in. So it's kind of, but it actually helps. It's in their lungs. It helps to open up those airway sacs and kind of feel so they can develop properly. But normally at the time of vaginal delivery, they come out and a lot of that fluid is squeezed out. So it helps. As soon as they start making that cry, they open up those air sacs and they can start exchanging that oxygen the way it's supposed to happen. When a child is delivered through a hysterotomy, through that cesarean incision, they don't get that squeeze. So we do see a little bit of more respiratory issues after. And it's just a transition thing. They just have to kind of cough it up. So sometimes those kids may spend a little more time with nursery or even require like some CPAP, some continued positive airway pressure, something like that, level of gas to kind of open up those lungs. So that's one of the biggest risks associated with babies. Every once in a while, they kind of get crazy, go real fast, and you may cut the kid. So that's pretty rare. And sometimes that's just an emergent situation. We just have to get the kid out as quickly as we can. That's always small. Okay, so to mother, it's major surgery, right? So increased bleeding, blood clots, wound infection, reactions to anesthesia, surgical injury, or around your bowel, your bladder, those kind of things to try to play with this sometimes, and we don't want to stay in your own section there. So it talks about inflammation, increased risk during future pregnancies. Number one risk for postpartum infection is just route of delivery, C-section's that. So something you have to definitely watch out. It's a longer recovery, too. They have that incision there. So forceps vacuum, this is also to help out with delivery. So, once again, it's one of those things where it's not about, it's about the kid's safety. So you kind of have to balance, and a lot of things you'll do, I think, not only in obstetrics, but in a lot of things. You're not making a straightforward choice. You're balancing risk and benefits, is what you're doing. And so at this point, this is one of the things where we think that the benefit outweighs the risk. Indications like it talks about, exhaustion, prolonged second stage, cardiac pulmonary disease. Once again, this is one of those, sometimes those patients that get that far and they can't really push. We have to help them, we have to assist them. So we do forceps or a vacuum to help to kind of deliver with that push there. So, maternal exhaustion, one of the things, like I say, we talked about pushing 2-3 hours. Some of these ladies, some inductions may last like 48, 72 hours. And they're just exhausted and become quite challenging for them along those lines. So fetal indications, so failure to progress there at the low station. So once again, now, there's different levels of station. That's once again, it comes back to knowing exactly where the kid's located. It has to be low enough for us to apply this. If this kid's like -2, I'm not putting a vacuum on. This kid's not taking. But anything that's +2 or above, they would be probably an opportunity for them to need this, or if you utilize this as a tool that you could utilize. So. Failure of the fetal head to rotate. You can't apply forceps on a kid that's up to training birth. They need to kind of spin around, and you can kind of maneuver them as well too. Fetal distress, yeah. Once again, it talks about kind of that indication for that episiotomy. The kid's really hurting and needs to get out. So just throw a vacuum on it and help it out. You know, if it's maybe it's 4 or 5 pushes away, well, we'll just need to get it out in one push. Control fetal head and vaginal breech delivery, and that's what that bottom picture is showing there too. Okay, so this is a breech delivery. You can see that the head is still inside. The rest of the body's out. That is the mom's, you can see the spinal column, so that's her buttocks towards the bottom, her abdomen towards the top. These are Simpson's forceps. They're specific for breech deliveries, is what they are. So the problem with, once again, with breech delivery is you get the body out, but now instead of getting this head to flex and come through right, it's got this chin that gets stuck on it. And so it's just kind of stuck there. So what Simpsons do is they help to kind of wrap around the kid's head and get it to flex. So we can once again get to that smallest diameter for it to come out along those lines. So contraindications, breech. You can't put forceps on like a kid that's just pushing breech, right? The whole body's got to be out before you do Simpsons, right? You can't. There's no forceps that are designed to wrap around the legs and pull out the legs. Should not be used vacuum for preterm. This is less than 34 weeks. Because of the pressure, because of the risk for getting on the fontanelles or something along those, we don't want to potentially cause, it's just a higher risk of bleeding of internal hemorrhage. So under 34 weeks, you can do forceps. You can do that, but you can't do the vacuum. Face presentation, you can't get to the right position. It doesn't really have a good picture. Yeah, then its picture is further down, so let me show you this. So you can see the diagram there. This is the way that those forceps are supposed to lie. They're supposed to kind of come across the ear, kind of around the jaw area. And so if you can imagine if that kid, now that kid's looking towards the skin, but if it's looking out of the vagina, looking straight ahead, you can't get in that right position and you're going to hurt the kid. Fetal coagulopathy, this is something you got to know. Like either the mom has some genetic complication or we've seen some kind of concern for anemia or some platelet dysfunction or something like that on ultrasound, and that's been determined. So this is extremely rare, but it's something that should be well known before delivery. But you would not do any vacuum or forceps with a kid that has fetal coagulopathy issues. Previous scalp sample. So this is not done very much as well too, but you know the whole point of when we watch that heart rate is to ensure that they're not acidotic. We want to make sure that they're oxygenated well enough, that we're seeing that appropriate heart response that we're after. And so when we start to have pattern issues, we get concerned about, are these kids being oxygenated enough? Are they becoming acidotic? And so one thing that they would used to do is they would actually collect fetal scalp blood samples. They'd have the mom place a speculum, she'd be laboring along, they'd be able to see the kid's head, and make a small little nick in it, collect the sample, and send it off to get the pH and kind of see what it was. Now it's something they certainly recommend not doing. You can do forceps but not vacuum. You can't do vacuum. That's pretty rare now these days. They don't really do it because it just didn't really, it didn't decrease the number or help with the delivery process. So this is just an example of vacuums. They have different models. There's kind of that bell shape on the left there. It's soft, it's flexible, as it's demonstrating in the picture in the middle, it's collapsible. And that's what you need. You need it to be able to collapse to kind of get into the vagina so you can get around the kid's head. And some of them have a hard cap to them as well too. The old school ones actually hook up to the wall when you suction, but now they have those handheld ones like the one on the left. You just kind of pump up on your own. All of the ones that you have on your own as well too, if you ever have to utilize these, the pump itself, it'll have a gauge on it so you can see your pressure. And they're nicely drawn so that you can see the red don't go up to that high. The yellow is kind of warning, and the green is kind of your ideal pressure. And we think that's an adequate pressure to where you're not going to cause significant trauma to the kids. They're gonna get like lacerations. They're gonna get cephalic hematomas to where they have a little bruising on their head and stuff like that. But we're talking about like retinal hemorrhages, subgaleal hematomas, those kind of real serious kind of lifelong complications. I'd say the other thing, if you ever do forceps vacuum, you always have to be willing to abandon what you're doing. You can't be heroic saying, I got that kid out, 800 pulls. No, that's not going to do it. So kind of the rule of thumb is 3. If you can do it in 3 times, 3 pushes, 3 pulls, and you make progress, and yeah, that's okay. But you can always got to be willing to abandon what you're doing. So I think what I like about this picture too is on the right side, a lot of people get concerned about forceps and scared about them, that it's going to crush my kid's head. And as you can see on the right, when they're engaged, they can't go any closer together. You can't like clamp down on them and squeeze it down or anything along those lines. That's not what they're designed to do. They're not designed to grab the kid's head and pull the kid out. They're designed to open that space in the mom's vagina. That's what they're designed to open. And so they kind of make kind of pave the way, almost is what they're doing. And so unfortunately then the complication becomes, like it says there in the first one, vaginal laceration. So pretty high significant risk for 3rd and 4th degree laceration, as well as you start to get into these urethral lacerations and bladder lacerations as well. So it's high risk for that. And once again, that's something that at that point you've got to identify those lacerations as best you can after delivery, because that's your best time to get the best repair. Complications, so for fetal side, forceps, we talk about bruising, laceration to the face, injury to the scalp, cephalic hematoma, once again, those retinal hemorrhages, those kind of things. Facial nerve damage, that's pretty rare, but once again, this is all right, so important for you to know exactly which way the baby's lying, what direction they're pointing, because they have to go in the proper way. Injury to the fetal scalp, we talked about that, those lacerations. Most kids will have some kind of evidence that, hey, that vacuum was there. Normally, and this is even evident for moms that push for a long time. I mean, they've got this large kind of molded and handicap. And your kid's going to be shorter tomorrow than they are today. I mean, it's just, that's the way the heads are designed, right? They're designed, the sutures are not fused, they're designed to ball, they're designed to kind of fold so they can get out and all those things. Birth asphyxia, we've talked about that. So once again, that birth asphyxia, you've got to be willing to realize that this is something you have to abandon. You know, if you're not making progress, then you need to go on to a C-section. And that sometimes, that's maybe one of the other points about the benefit of a vacuum versus a forceps. If I've got a kid that's in distress, and next push, I mean, I could, you get the vacuum on and potentially deliver the kid within, 3 or 4 minutes. Versus realistically, for me to do a C-section, for us to get our team all the way back to the OR, to get everything going, that's probably at least 10 minutes, for most places. I mean, it's just going to be really honest. So sometimes it's a gamble about your time. If you're going to be successful, but I need to get this kid out as soon as I can. And that's it. What questions? Any questions generally about healthcare? You guys are in a good field. Yes?
Where do PAs fit into the obstetrics
Got that
category?
question last year as well. You guys are in a great field. You've chosen wisely in your career. PAs are going to be utilized more and more, I feel like. on sometimes like obstetric labor deliveries, about triage, I think we'll see that. Seen some that go on and do extra training, depends on the provider they're working with, but we'll maybe do some first assist with cesarean section, stuff like that. If you do a C-section, there's a team, right? I don't deliver a C-section without like some kind of certified first assist, because it just takes that, it's just a physical surgery is what it is. But so there's definitely that. Always office stuff. I mean, you'll always be helpful and utilized immensely in that. As you know, healthcare is getting to lean as lean as you can. You guys, I mean, it's the honest thing, you're cheaper than physicians, you know, and so they like you along those lines, and start utilizing you for that. But definitely, I feel like there's always larger facilities that have significant obstetrical triages and stuff along those lines. So definitely kind of mid-levels will be available there that can help manage those patients. Definitely. There was talk a long time ago, there's kind of programs that have kind of midwives that help out with labor, but you always have a physician on backup for C-section and stuff like that. I totally foresee, you know, kind of a similar situation for PAs as well, to help manage with labors and stuff, but you have a physician that's a backup for those C-sections and difficult cases and things along those lines. So, no, there's definitely, you guys have chosen wisely in your field. Any other questions?
How long have you been an OB?
Been out for 4 years from residency.
Where'd you do residency?
Akron, Ohio. Shoveled snow for 4 years.
So why did you choose Ohio?
Well, I just, you know, shovel snow and there's a few babies that show up. I don't know if that along those lines, but we loved it. I'm originally from Oklahoma. My wife and I are from Oklahoma. Just felt right. Found a good place to train and great facility. Met my wife's best friend there, so it was real fortunate time. Beautiful. We so miss Ohio at this time of the year because the falls are gorgeous. Right, I bet their temperature